Good day, I'm Zhejiang from Taiwan. And today I want to share the experience of monitoring adherence to osteoporosis drugs and its associated outcome in Taiwan using health insurance database. And our study was supported by our clinical center and National Science Council in Taiwan and had no conflicts of interest. And quick review of the background. Osteoporosis is characterized by decreased bone mass, deterioration of bone tissue, and disruption of bone architecture, which will increase the fracture risk. And it's also a major public burden in developed countries. What's more, patients with prior osteoporotic fractures, they will have twofold increase in the risk of future fracture. So secondary prevention of osteoporotic fractures is a standard practice worldwide. And among osteoporosis drugs, bisphosphonates are recommended as the primary pharmacological therapy for secondary prevention of osteoporotic hip fractures because it has shown it can lower fracture risk by 30 to 50%. However, long-term compliance is necessary to ensure optimal therapeutic efficacy. Unfortunately, less than 50% of the patients will complain during the first year after their treatment initiation. And several studies using claims database have estimated the impact of compliance on preventing further fracture events and found being compliant can have 20 to 60% lowered fracture risk. And the reimbursement scheme in national health insurance in Taiwan is that osteoporosis drugs were only available to patients who already had osteoporotic vertebral or hip fractures. So that provides an invaluable opportunity to assess the impact of compliance on outcome in patients who already had osteoporotic fractures. So our study group conducted a study entitled Alendronate Adherence and its impact on hip fracture risk in patients with established osteoporosis in Taiwan. And the significance of our study is that previous studies focusing on treatment compliance and its impact on fracture risk mainly conducted in developed countries, and data in Asia region is lacking. So our study objective is to describe the first-year compliance of patients initiated on Alendronate therapy after their osteoporotic fractures. And second is to assess the impact of compliance on the risk of subsequent hip fracture risk. So let's move to the method part. The data source we used was the National Health Insurance Research Database, abbreviated as NHIRD, and it contains all demographic data for enrollees and all information regarding healthcare professionals and facilities, and all service claims from inpatient, outpatient, and contracted pharmacies for reimbursement purpose. And from now, the national health insurance system in Taiwan covers over about 100% of Taiwan population, and it's about 23 million. So the study design of our study is retrospective cohort, and from 2003 to 6, patients aged above 50 years with new osteoporotic fractures and new to Alendronate therapy were included in our cohort. And the index date was the first day on which patients received an Alendronate prescription. And the baseline period was the 1-year period before the index date. And in order to ensure that index fracture was related to osteoporosis, patients they have to have at least one osteoporosis-related claim during the baseline period. And if patients who had experienced any study outcome during the baseline period or whose index fracture was associated with car incident or high-impact trauma, then in that case, patients will be excluded. Moreover, if patient had diagnosis of Paget's disease or malignant neoplasm, then patient will be excluded also. And then the follow-up period, when assessing the compliance with Alendronate, the follow-up period was the first year after treatment initiation. And as for the assessing the impact of compliance on fracture risk, the follow-up period was start from the index date to the first date of incident hip fracture or to the end of the study. And as for assessing the compliance with Alendronate therapy, we choose Alendronate as our study drug because it is currently the only oral bisphosphonate that approved for insurance reimbursements for osteoporotic fractures. And we calculate the review compliance as the medication possession ratio, which is known as MPR, for the follow-up period. And it's calculated as dividing the total number of defined daily dose patient received by the follow-up period. And we use MPI above 80% as good compliance in primary analysis. And we further examine the result by adjusting the cut points upward and downward. And the main study outcome of our study was the incident hip fracture. And we retrieved the data from inpatient claims only. And other covariates including index of demographic characteristics and other covariates related to fracture and comorbid conditions that could increase fracture risk such as Alzheimer's disease, DEM, and stroke, and other complications that could interfere osteoporosis fracture risk. And we used time-to-event analysis to assess the impact of compliance on hip fracture risk. And because the compliance can change over time, so we constructed multivariate Cox proportional Hesa models with time-dependent covariates for compliance. And we did a series sensitivity analysis to test the robustness of our study by changing the threshold for good compliance or included it as a continuous variable. And we also tested our results in different subgroups, in different gender, fracture risk, and age group. And we also examined our result in patients not on hormone replacement therapy and excluding the data for patients who had an instant hip fracture event within 6 months after treatment initiation. So let's move to the result part. Eventually, there were about 9,000 patients were included in our cohort, and we found only 38% of patients were compliant to their treatment during the first year after their treatment initiation, and the mean MPI was about 60%. And we also found female patients and younger patients were more compliant to their treatments. And here's the baseline characteristics of our study cohort. And we found compliant patients would tend to be younger and had more cataracts and hypothyroidism, and more exposure to hormone replacement therapy. And here's the result from time-dependent Cox regression model. And we found compliant patients had 70% lower fracture risk as compared with non-compliant patients. And what's more, older age with other fracture history and with DM, and ever-exposed exposure to benzodiazepines were also associated with increased fracture risk. And we found there's a trend for lowered fracture risk in patients who ever exposed to hormone replacement therapy. And this table is the result of sensitivity analysis we done, which I mentioned in the method part. And we checked the threshold for good compliance and included it as a continuous variable, and tested results in different subgroup analysis and found consistent results. So our retrospective cohort found Taiwanese patients with new osteoporotic fracture and new to treatment, the compliance status was suboptimal because only 38% of patients were to be compliant. However, compliant patients had significantly lower fracture risk as compared with non-compliant patients. And it is difficult to make a direct comparison of compliance rates among published studies because of their use of different covariates for adjustments, such as age, gender, fracture history, and medication of interest. And to date, several studies have used claims database to assess patient compliance in the state, Canada, or United Kingdom. And they found the first-year compliance to the osteoporosis treatment was ranged from 60 to 70%. And we found 60% in Taiwan, which also suggests that the compliance status in Taiwan was suboptimal. As for the impact of compliance, studies from the state, United Kingdom, and Belgium found being compliant can reduce fracture risk by 20 to 60%. And the divergence from this study result might be different selection in patient population and fracture outcome and medication of interest. But when we look at in the study with a similar study design, like our study and Belgian study, we found similar results. As for the sensitivity analysis, most studies using MPI above 80% as the threshold for good compliance, but some authors might think that be arbitrary. So we varied the threshold for good compliance in steps from 70 to 100% and found consistent results. And the benefit of compliance was pronounced even when the alendronate therapy was for secondary prevention. And the most pronounced reduction in patients was in patients with no history of fracture prior to their index osteoporotic fracture. And the strength of the study is that it is the first large-scale one in Asia to assess the association between treatment compliance and the fracture risk. And with a longer follow-up period, with up to 4 years in our study, and we include various covariates for adjustment. But there is the inherent weakness of an observational study and administrative database, because there was residual confounders. There's a lack of socioeconomic covariates in our national health insurance research database, so we cannot exclude the possibility of confounding by lifestyle. And other important covariates related to osteoporosis, such as BMI, smoking status, and caffeine intake were also lack of in our health insurance database. And the second point is that we cannot exclude the possibility of misclassification of compliance, but we comprehensively capture prescription claims from inpatient, outpatient, and contract pharmacies and follow patients in a longer period, which will minimize the chances. The last point is that we found patients who received HRT may have benefited from its protective effect, but consistent results were found even after excluding data for those kind of patients. And the final point I want to address is some policy implications. Because the main policy of Taiwan's national health insurance regarding osteoporotic fractures was secondary prevention. In terms of osteoporosis, drugs were only available to patients who had osteoporotic vertebral or hip fractures. But in our analysis, we found if patients had fracture size other than vertebral hip before their index osteoporotic fracture, they had twofold increase in the risk of subsequent hip fracture risk. And moreover, older patients had high fracture risk as well. So primary prevention might be considered in these two patient groups. To sum up, the compliance status among Taiwan osteoporosis patients new to their osteoporosis treatment was also suboptimal, but compliant patients still had a significantly lower incident hip fracture risk as compared with non-compliant patients. And in real-world setting, osteoporosis drugs will not work optimally unless patients actually take them. So every effort should be made to gain greater insight into the factor associated with poor compliance and to initiate interventions to improve patient compliance. So that's been my presentation. Thanks for your attention. Any clarifying question for Zijie? Well, if not, then I think my co-moderator and I will start the